like 2 more minutes. So Sonal, please note down Himanshu ji, Dr. Himanshu Pandya also join. So make him unmute. Good morning, Dr. Himanshu.
Good morning. Good morning, everyone.
Good morning, Himanshu ji.
Morning.
So,
Good morning.
Anil ji, do you want us to make a few more unmute from your side?
नहीं डिक्लाइन मत करो.
We are live on. Do you want us to make a few more unmute from your side?
नहीं डिक्लाइन मत करो.
I think the YouTube maybe.
We are live on.
Do you want us to make a few more unmute from your side?
नहीं डिक्लाइन मत.
Sonal, I think the voice is coming from YouTube channel. Can you maybe?
We are live on.
You can close that. Yeah.
अभी ऐसे ही हुआ था ना.
Okay, I'm muting everyone and then I'll start unmuting
Okay.
Everyone. Just in case अगर आपको unmute होना होगा ना तो एक chat में मुझे मैसेज ड्रॉप कर दीजिएगा प्लीज. Hello, Manju.
Hello everyone.
Yeah, we'll wait 1 more minute and then we'll get started. So if you guys are not speaking, please mute yourself. And if you're the speaker, if you mistakenly mute yourself, just message Sonal. So she will make you unmute again. Okay, so I think we will start. So good morning, all the viewers from US and Canada, and good evening, all the viewers from India, Chhattisgarh. So I, Ganeshkar, President of North America Chhattisgarh Association, I welcome everyone this webinar. And before we will start, I will just give you high level what is the NACHA. So NACHA is a North America Chhattisgarh Association. Is a non-profit 501c3 association registered here in US. So this is the NRI Chhattisgarh NRI Association, and we have presence in Canada, US, Singapore, Australia, and few other countries. So we have more than 200 Chhattisgarh NRI connected to our association. And what is our vision is basically we promote our state outside of India, and also we promote like Chhattisgarh heritage and culture, and also we help our people here outside of India as well as India, Chhattisgarh. So and we take like lots of initiative for our state, like Udan, that is the one of the initiative that we are doing to sponsor poor kids for their higher education. Chhattisgarh project that we are running for language translation from Chhattisgarh language to other world language. And also we do, celebrate our Foundation Day we celebrate all the like major festival within our community. And also as a, you know, when you come from India, you're first like you're India. So we also, you know, support lots of Indian initiative taken by Indian government, working closely with all the council general across globally like embassy, and working and helping them to promote India as well. So this is like, this is our association, and we have our website www.cgnacha.com, and we have more than 200 NRI connected to our association at this moment. And I am sincerely thanks like AAPI, American Association of Physician Indian Origin, for supporting this vision to provide, you know, to helping India during this time. They have done extraordinary work during the COVID time, helping and educating across India, as well as their involvement in here in US. And I also sincerely thanks IMA, Indian Medical Association, Chhattisgarh chapter and Raipur chapter, because we have we gone through major challenge during the COVID time, and taking IMA has done extraordinary work helping our community in India and Chhattisgarh, and with this help, you know, we save lots of life. So I will not take much time, and you guys we can do the panel discussion, and I will introduce IMA President, elected President Anupama, Dr. Anupama Goti Mukalaji, to please share what is AAPI, how AAPI is doing, and what is the AAPI vision, and how AAPI is helping our community during this time. Thank you so much. Handing over to you, Dr. Anupama ji.
Thank you, Ganesh. And, good morning to all my US, Canada colleagues, and good evening to Indian colleagues. I'm Dr. Anupama. I am from San Antonio, Texas, in United States. I'm a pediatric anesthesiologist and currently president-elect of AAPI, but my term will start in next 5 days as president of AAPI. So AAPI is the organization for physicians of Indian origin. We have close to around 100,000 Indian physicians in United States, and about 15 to 20% of the second generation, the kids, are of Indian origin in this country. So it's a large group of physicians who are located all over the country. We serve every position in this country, starting from in the rural areas of the United States to academic government hospitals, university hospitals in United States. So AAPI represents all these physicians. So any issues or anything we can do is through this organization. We approach the government, we do social service, we do charitable works. Coming to United States, we have 130 chapters, and we have specialty alumni chapters all together. So, and in India, we do service. We have a charitable foundation wing, and they do have some clinics in India. They do service in India. I think they see close to 1 million patients every year, around the year, through these clinics. So, unfortunately, this year the COVID has, we never thought that COVID do this much of damage for us in India. So we are unfortunate. We were in this position last year in March, and our two doctors here, Dr. Himanshu Pandya and Dr. Avinash Gupta ji, they have seen practically when the first COVID hit in March last year, 2020, they were in the middle of the COVID pandemic. And right now we see that same situation in India, and they are the experts of how they manage COVID, and they have a lot of tips and guidance, and they're going to give some guidance for all of us from the state of Chhattisgarh today. And any help or anything coming, we did raise some funds for COVID, and we are happy to help the state of Chhattisgarh through the government of Chhattisgarh if there is anything. And I'm very happy to contact the government of Chhattisgarh, Chief Minister, Health Minister in a different call, and then see what we can do. And you also, if you have any requirements, please do contact Ganeshi, and we can always get together together again in future. So I want to start without wasting much time. I want to introduce our speakers. First speaker is Dr. Avinash Gupta. Dr. Avinash Gupta is a practicing cardiologist in Lakewood, New Jersey state since 1994. He owns his own practice where both he and his wife, Dr. Geeta Gupta, internist practice, they both practice. He's board certified in cardiology, nuclear cardiology, and clinical lipidology. He was born in Ranchi, Bihar, India, and moved to United States in 1986. Dr. Gupta serves as Chief of Cardiology at Monmouth Medical Center Southern Campus. He's also President of Monmouth Ocean County Association of Physicians from India, President-elect of Medical Staff at Monmouth Medical Center Southern Campus. He's a member of American College of Cardiology, National Lipid Association, and the Medical Society of New Jersey. Dr. Gupta also serves as president of Bihar Jharkhand Association of North America. And I welcome Dr. Gupta, and we'll start your first presentation. Thank you.
Thank you, Dr. Anupama Gotimukula, for giving us this opportunity. It is an honor and privilege to share the panel with Dr. Himanshu Pandya, who you will hear next. He has treated thousands of patients with COVID and actually suffered from COVID himself and got over it. And Dr. Mahesh Sinha, President IMA Chhattisgarh, and Dr. Vikas Agarwal, President IMA Raipur. And thank you, Mr. Ganesh Kar and Dr. Anil Jain for organizing this. So basically, the topic is very appropriate, what's new and do's and don'ts. So as a president of Bihar Jharkhand Association of North America, I have done a lot of telemedicine services, and I know that doctors in India are doing a fabulous job. Actually, they are doing very well, but they are overworked. And we were getting calls that there are no hospital beds, no oxygen, and no medication. So that's why we sprung to action and we sent the help. We did telemedicine. But right now, the question on everybody's mind is what's new. The new thing is the variants. As you know, the Delta variant came from India, and now there is Delta Plus. And the bad news is that it spreads very fast. It's highly transmissible. I mean, some people are even saying that even if you pass a person, you can get it. But the good news is that the vaccines are still effective against these variants. Pfizer did a small study which it is 88% effective against the variant, Delta variant. So that's the good news. So to prevent the third wave, which is on everybody's mind, and it's a matter of time, it will come because when the government lifts the lockdown, people think it's safe, but it's not safe. Government lifts the lockdown for economic reasons because, people have to work, they have to make money, they have to earn their livelihood. So we should not get carried away and start rushing and doing everything like it is back to normal. So we still, so it will depend on the prevention of COVID. A third wave will depend on two things. Number one, if we follow the COVID appropriate behavior, which is again masking, physical distancing, hand washing, and avoiding large crowds. And the other way we can prevent the third wave is vaccine, vaccine, vaccine. So we have to vaccinate people. And unless 70% of people are vaccinated, we are not going to get over it. And right now, the beds and oxygen are not a problem, and we cannot prevent the third wave by adding more beds or providing oxygen. I mean, we have to train the doctors, and we are in Bihar and Jharkhand. We are also training the health workers or even the volunteers to go around with masks and hand sanitizer and pulse oximeter and screen people and know how to recognize COVID, like signs and symptoms of COVID. They can check their oxygen saturation and tell them when to go to the hospital. They check their blood sugar and blood pressure. And the other thing new is the mucormycosis, which is a hot topic, and everybody is talking about it. And people have been talking why there was no mucormycosis in the first wave, why there was so many in the second wave, and why there is no mucormycosis in America, rest of the world, but only in India. So, and there are multiple reasons for that, and we have to deal with each and every point separately, like steroids, indiscriminate use of steroids. This could be because of this variant, which was found in India. And of course, the diabetes, uncontrolled diabetes. Many people actually don't even know that they have diabetes when they get COVID. And some people are getting COVID, diabetes because of COVID. There is malnutrition. There is repeated use of same masks and moist and humid conditions. But most important is the use of water in the nebulizer or humidifier. So we have to use the distilled water there. So hygiene is the most important. So we have to, and steroids should always.
अविनाश जी, आप शेयर कर रहे हैं क्या कुछ स्क्रीन?
No, not right now.
Okay.
So, the steroids should only be used under physician supervision and not indiscriminately. And I can tell that from my experience in dealing with patients from India, we have been using indiscriminately, a lot of medications which are not even recommended or proven. So the first thing is they start. We cannot blame ourselves, because when people are dying and when our back is against the wall, we use what. But we can, in India, we can always look at the AIMS Delhi recommendations, ICMR and Government of Health, Department of Health of Government of India, and they come out with updates every now and then. So to start with, what does not work is, hydroxychloroquine, favipiravir, the antibiotics, Zithromax and azithromycin and doxycycline. They should be used only if there is a secondary bacterial infection, but not in everybody. And people who are getting into hospital, broad spectrum antibiotics like mirapenem are being used. So these can lead to mucormycosis later. And then antivirals also. Remdesivir in the trial has shown that it just cuts the duration of illness from 14 days to 10 days. So it has no effect on mortality. And it should be used when the virus is there in the viral phase. So when the virus comes to the body, it is there for 9 days. And after that, people get sick because of what the virus has done to the body, which is mainly two things: inflammation and thrombosis. So that's why for inflammation, steroids are important, and for thrombosis, anticoagulation is important. So I can say that the only three things work in COVID. One is a steroid, two is anticoagulation, and number three, oxygen support if you need it. So it is very important to know. So remdesivir can be used when patients are coming in the acute viral phase. So I would like to share some slides. Can you see my slides now or no?
Not yet.
Okay. Oh, I have to share the screen. Okay. Okay. Can you see it now?
Yeah, we can see.
Okay. So I'm trying to move it. Okay, so it is important to know the classification of COVID because as we know that it's mild, moderate, and severe. And
Excuse
the
me,
mild.
Dr. Gupta, you have to change your mode actually. All the slides are visible.
Oh, okay. So let me see.
Click on the slideshow.
Yeah.
That's I had a problem with that before. So
On the
yeah.
bottom right side, you will get it.
Yeah.
Yeah. No,
Is it good now?
yeah.
Yeah.
It's good?
Yeah.
Okay, so as we know that 85% of people will get better at home. So if we can treat them at home, then we can prevent clogging of the hospitals. Then we don't have to worry about hospital beds and oxygen because only those patients should go to the hospital who need the hospital. And then, as I said, we'll go over the antivirals, steroids, anticoagulation, and supplements, and how to prevent complications. So this is important. So mild cases are fever and uncomplicated upper respiratory tract infection without shortness of breath or without low oxygen. So these patients can be treated at home. And then there are moderate patients who have pneumonia, but no signs of severe disease. Their respiratory rate is more than 24 and oxygen is less than 94. So that's when everybody should have a pulse oximeter at home and they should check their oxygen. If it is less than 94, then they go to the hospital. And then severe cases are respiratory distress requiring mechanical ventilation, non-invasive or invasive. Their respiratory rate is more than 30 and oxygen saturation is less than 90. So as I said, 85% of people will get better at home, 10% will need hospitalization and 5% will need ICU. So in the initial, and also people in India, they are getting HRCT as the first test. So it's not necessary to do HRCT. Because RT-PCR takes 3 days, but HRCT they can get right away. So they get HRCT and they're repeating it like every 3rd day, which also is not necessary. So we should just look at the patient, take history, physical exam, and most important is to look at the comorbidities, like age more than 60 years. If they have diabetes, hypertension, cardiac disease, chronic lung disease, cerebrovascular disease, dementia, mental disorder, chronic kidney disease, immunosuppression, obesity, and cancer, then they are at increased risk or their history of smoking. And one more thing, the monoclonal antibody, which was not available in India, has been made available now. So if the high-risk patient who comes to the emergency room and he is at high risk for progressing into severe disease, they are given monoclonal antibody in the ER and they are sent home. And that there is a data that it works. So that we have to include. And convalescent plasma does not work. I mean, it has been taken off the protocol now. So we should, for a baseline, we should do complete hemogram and also basic metabolic profile, including liver and renal function. That will help us in treating them, giving them remdesivir or anticoagulation. And of course, inflammatory markers like CRP, which is marker of inflammation, ferritin, IL-6, which can predict cytokine storm, D-dimer, which can predict thrombosis. So we can use it both for prognostic and monitoring, and arterial blood gas. ECG, and if we suspect that heart is involved, then we can do cardiac biomarkers like troponin. And investigations, of course, related to diagnosis and management of comorbidities. And if there is anything going on in the local area, then we can check on that. And if there is sepsis, we send blood cultures. And these are the poor prognostic markers, like lymphopenia, elevated liver enzymes, elevated LDH, elevated CRP, elevated IL-6, elevated troponin, D-dimer, ferritin, or acute kidney injury. And these are, everybody should get a chest X-ray at baseline who are getting into the hospital. And chest CT at admission is rarely needed unless there is pulmonary or extrapulmonary complications. But it may help identify co-infection, such as if in India there is some TB or something else going on, then we are using steroids that may be disastrous. And if patient is deteriorating clinically, then we do it. And we do CT angiography if a pulmonary embolism is suspected. So mild cases are less than 9 CT score, moderate is 9 to 15, and severe is more than 15. And initial management is close monitoring, and oxygen saturation, we monitor that. And antibiotics, we should not prescribe routinely unless there is clinical suspicion of bacterial infection. And symptomatic treatment with antipyretics and antitussives, and cautious fluid management, which is maintain euvolemia. So we chart the input and we output, and output plus 500 ml should be the input. Pharmacotherapy, these are the 4 cornerstones. One is antivirals, then anti-inflammatory, anticoagulation, and supplements. And this is based on the pathophysiology of the disease. When the virus comes in the body, the first week, I mean, you have fever, that's the time to give the antiviral. And then second week, there is inflammation and thrombosis. So everybody who gets into the hospital should be started on prophylactic dose of anticoagulation. And in the second week, if their CRP is high, if they have hypoxia, then they definitely should be started on steroids. And steroids are in the recovery trial, it was 6 milligram of dexamethasone for 5 to 10 days. So there are a lot of, I won't go into these details of what WHO says, what CDC says, and what ICMR says in India. But suffice to say that this hydroxychloroquine, azithromycin, ivermectin, favipiravir, they are not being recommended anymore. And remdesivir also is used mostly in the hospitalized patients. And convalescent plasma also, there is insufficient evidence. But monoclonal antibody, yes, we should, it says not available in India because it's an old slide, but it is available in India now and it should be used. Anti-inflammatory agents like glucosteroids, again, I will say that patients should not use it themselves. It should be used under physician supervision. And physicians also should not use it indiscriminately. Dexamethasone 6 milligram daily or equivalent for up to 10 days, 5 to 10 days. And tocilizumab is again recommended only in progressive cases with raised inflammatory markers in addition to standard of care. So patient is admitted to ICU within last 24 hours, their oxygen saturation is going down, they are getting sick, then it can be used in addition with remdesivir. So there is some benefit to that. And in India, they are also using baricitinib, but in America, it's not approved. Anticoagulation is very important. As I said, only 3 things which work is anticoagulation, steroids, and oxygen. And I should add a monoclonal antibody to that also. So anticoagulation prophylactic dose everybody is recommending. And we have to look for contraindication to anticoagulation, and role of coagulation markers to guide decision making is uncertain, but in India, people are using D-dimer as the marker, but CRP and D-dimer will definitely help us guide our therapy. And supplements, everybody is getting in India as well as here, vitamin C, zinc, and vitamin D. So there is insufficient data to recommend either or against. But we think vitamin C builds up immunity, and so there's no harm in using it. So we have been using it, but people should not, patients should not think that they are the cure for COVID. Just like, some people think the cure for COVID is steam inhalation or gargling, but they won't hurt, they're good. So step-up care should be considered when there is progressive worsening of PF ratio, hypotension requiring vasopressor support, worsening mental status, and multi-organ dysfunction syndrome. Then we have to consider shifting to ICU. So coming to antivirals again, we went over this: hydroxychloroquine, azithromycin, ivermectin, favipiravir there. So this is just a repetition of the previous slides, looks like. Okay, so the remdesivir, convalescent plasma, monoclonal antibodies. So remdesivir in the first antiviral phase, convalescent plasma is, if given early, it may help, but it's not being used in late cases now. Monoclonal antibodies do help. There is evidence for that. So again, remdesivir is best, effects are best seen with early presentation and those requiring only low flow oxygen. And their kidney function and liver function have to be monitored. These are the doses, and then contraindication again in liver or kidney failure. Then this is the convalescent plasma. If used early, it can help. But there is, of course, some risk. This is the monoclonal antibody. So patients who are already hospitalized or who are requiring oxygen, they are late in the game. It should be used early on. For people who are high risk to progress to severe disease. And steroids, we base our recommendation on the recovery trial, which was done among hospitalized patients. And there was a benefit in 28-day mortality. And so patients who needed oxygen, they were the ones who benefited. Patients who did not use oxygen, did not need oxygen, and it was used, there was a trend towards worse outcome. So anti-IL-6 therapy, which is the tocilizumab or Actemra, is in combination with steroids, is now recommended for patients who are recently hospitalized, who admitted to ICU within last 24 hours, and who require invasive mechanical ventilation, like what we call cytokine storm, and there is single dose to be used. Baricitinib, we don't have experience with that because it's not approved here. So again, these are the cornerstones. Anticoagulation, meta-analysis of hospitalized patients did show that COVID-19 found an overall venous thromboembolism prevalence of 14%. So it's high. So that's why we have to use a prophylactic dose as soon as the patient is admitted to the hospital. Outpatient use of anticoagulation is not shown to be beneficial, but depending on the overall clinical situation, like if the patient's CRP is high or D-dimer is high, we can use it. Prophylactic dose is recommended. So the supplements, again, as we said, vitamin C, vitamin D, zinc, I mean, there is no data to support it or to say that we should not use it. So these are the summary, again, antivirals, anti-inflammatory, anticoagulant supplements. So basically oxygen is our, oxygen is very important. So patients who cannot get to the hospital, who need oxygen, We made some COVID care centers and provided oxygen concentrators. So our goal is 92 to 96%, and preferable device is non-breathing face mask, venturi mask, and high flow nasal cannula. Again, these are disposable, so please do not use them again. That may cause mucormycosis, and also the proper hygiene should be maintained. And these are some of the ways we can use. I want to leave some time for the question and answer. So, and also Dr. Pandya may have to say a lot. Oxygen device, low flow nasal cannula, face mask, non-rebreathing mask, venturi mask, high flow nasal cannula, non-invasive ventilation. In the nasal cannula, when we give, we can give up to 1 to 6 liters per minute, and that will translate to a FiO2 of 24 to 50%. And face mask can give us 40 to 60%. Non-rebreather 90 to 100%. Venturi 24 to 60%, and high flow nasal oxygen 21 to 100%. So then if we cannot achieve that, then we can go to non-invasive ventilation and close monitoring. And sometimes they do need intubation. But what is very important is in absence of, if the ventilators are not available, awake prone positioning is very important. Early proning in awake, non-intubated patients, all patients with respiratory distress can be considered and continue oxygen therapy. And a typical protocol is 30 to 120 minutes in prone position, left lateral decubitus and right lateral decubitus and upright sitting position. So that really helps. The contraindication to awake proning would be respiratory distress, need for intubation, hemodynamic instability or arrhythmia, agitation, altered mental status, unstable spine, thoracic injury, recent abdominal surgery, and relative or facial injury, neurological issues, morbid obesity, pregnancy, and pressure shock. So when to escalate to invasive ventilation, patients on oxygen should be monitored for work of breathing, increasing oxygen requirement, and hemodynamic stability. So the take-home messages are classification of COVID-19 is mostly dependent on clinical features. So no need to do HRCT and all the battery of tests all the time. Lab parameters, imaging play ancillary role. And remdesivir has role in moderate, severe selected disease. So remdesivir also was a problem in the second wave, and it was being black marketed, and people were hoarding it. So we have to concentrate on the what works, really works and proven, like steroids and anticoagulation. And steroids and tocilizumab, selected cases, have role in moderate or severe disease. Anticoagulation has role in moderate to severe disease, and no definitive role of adding supplements. And oxygen and other supportive therapy are of paramount importance. And now there is a something called long haulers or post-COVID syndrome. So we will have to deal with that, with the mental health issues also. And the long haulers, I mean, after 3 months, if they are still suffering, then we can go for pulmonary function test and other things. Thank you. I will give it back to Dr. Anupama to introduce Dr. Himanshu Pandya and take it from there.
Thank you. Thank you, Avinash-ji. That was very, very useful information. What exactly is COVID and how do we get the COVID patients to the hospital? Who needs, who does not need? What are the best medications for early COVID? And so that was a very good preview of the COVID. And I want to introduce the questions. We'll take it end of the talk. I want to introduce the next speaker, Dr. Himanshu Pandya. He's currently our regional director of AAPI. He's from New York. He's also board of directors, New York City Health plus Hospitals Corporation, NYC, Gotham Health, which is the largest public health system in the United States. He's also the incoming chair of AAPI Academic and Research Committee. And Dr. Pandya is the earliest physicians who managed COVID in New York when the pandemic struck, where patients were dying in thousands and thousands every day. He himself also had COVID, he recovered, and he followed certain own principles. And also, there was no guidelines at that time, and nobody knew how to treat COVID. At that time, he managed COVID and he survived. And looking after 1 year where we are. So let Dr. Himanshu Pandya welcome, and hopefully you can give us some insight about COVID right now.
Sure. Thank you, Dr. Gotimukla, for introducing me. I would like to thank North American Chhattisgarh Association and Raipur Hospital to giving me opportunity. Of course, AAPI, the family. I know Dr. Gupta, thank you so much for going in the details. We got a lot of information, mainly with all the audience, but I would go basically completely different route for the COVID. Since I was in COVID, and when it started in March 2020, my average day with the COVID positive patient, approximately more than 12 hours every day. I knew that at one point I'm going to get it, COVID, because there is no other way that I can protect myself after taking all the precautions. But on second week of March 2020, we started seeing patient. Our ER, emergency room, was full of the patient with the COVID. The reason I want to go in little background, because I want to give some information so at least we can move quickly. What happens, we treated patient, we had at that time hydroxychloroquine. We were giving patient went home. Some of the patient could not make it because whoever went to ICU at that time, it was almost 70% of the mortality on the ventilator. That was in March 2020, more than 70%. Patient went home. We were thinking, they got better. After a couple of weeks, they started coming back with either stroke, blood clot in the lungs, pulmonary embolism, and then we realized there is something wrong. Why these patients are coming back? We did not have the concepts of blood thinner at that time, anticoagulation on the discharge. Bottom line, somehow we were able to manage. I was in the epicenter of the New York City, where we have, I would say, so many patients with the COVID positive. We did not have resources at that time. The one principle I had it when I went through the pathology of the coronavirus at that time, since we did not have information, one thing that if you are resting, if you are become inactive, the virus had a propensity to stay in the lungs. So this is what I saw somewhere in the pathology. So I realized if I keep myself active, probably chances of getting this severe COVID might be less. Thanks God, I followed certain things and I rested 9 days at home and I went back to work. I did not have to take any medication. I recovered in 9 days with the COVID. That was in the end of March. What we looked at that in September, October 2020, we started seeing patient that again coming back to the hospital, but this time was different. The difference in March, April versus September, October, entire family was coming in September, October positive. So we realized whatever in the March and now September, October, it's different. Because before we had one person from the family positive, now it's coming with like 3-4 family members. So we realized the infectivity of the virus was very high in September, October compared to March, April. But March, April, since we did not have information, mortality was very high. Whoever came to the hospital or ICU. Then slowly, the vaccine came. I want to go, since this is all the history, I want to go mainly on the aspect of the clinical part. And if you know that, I know that in India, now I'm seeing more pictures on the social media. It's like a party, a gathering. But if you know that last Monday, there was a highest death in India than any other country. That was 4,600. And this was last Monday. So pandemic is not over in India. It's still there. And if you look at the death, now we understand there might be a lot of unreported deaths, but whatever the reported deaths we have, this is the data we have. In the US, we had it in January 2021, close to 4,500 deaths. Vaccine part, and I know that this is something we are going to concentrate on that. I know US has 3 vaccine and India has 3 vaccine. US 3 vaccine is Johnson & Johnson, Pfizer, and Moderna. Moderna and Pfizer are mRNA vaccine. I know Dr. Gupta went through that, but I just want to tell you, because what we are getting so many questions about getting vaccine. When people are going for vaccine, they come up with so much information. mRNA vaccine is not the new technology. Moderna is studying this technology for almost 10 years. So it was easier for them to make it vaccine in 6 months. Also, Moderna and Pfizer started enrolling patients from as early as July 2020. They had done trial, they came up with the data. Usually in the US, FDA when gives the permission to any pharmaceutical or manufacturer company, they give initially as an emergency use authorization with the term that they would still continue with the research. So when we had information in December, when they got approved, Pfizer first got approved, we had a data from 6 months. And whoever was participating in this vaccine trial, they offered me also to participate. But at that time, we were a little scared that we were not sure what is mRNA. So I did not participate, but few of my friends were participated. And in December, they got the letter, oh, you know, by the time, by the way, in October, you got vaccine. That was a Pfizer mRNA vaccine. It was real vaccine, not the placebo. So they were happy. So anytime vaccine will give you the effectiveness, it's not up to 6 months, but it works minimum 6 months. This is actually the main thing I want to pass it to everybody, that vaccine companies are not claiming that vaccine is forever is going to work. They are telling 6 months, they are still studying, and we'll have more information probably in a couple of months. mRNA vaccine does not alter the genetics. This is the most common question we are getting in the US for people not to get the vaccine. mRNA is just mimicking cell. Once they enter in our cell, they provide the spike structure on the cell. It mimics, it's a COVID virus, a COVID-19 virus, but it is not COVID-19 virus. It's just a structure that is created by mRNA, and that body is attacking on that and producing antibody. So we are getting antibody without COVID virus, and that's how we are getting immunity. This mRNA does not go to the nucleolus. If I tell you, anytime somebody wants to change the genetics, they have to enter into nucleolus. It does not go to the nucleus. It does not enter in the nucleolus. So bottom line is mRNA does not change the genetics. You have so many patients, they are not getting vaccine in the US because of that reason. Right now, the numbers we have that close to 177 million people got vaccine. And then slight about 1,000 people, according to the CDC data, got something called myocarditis. The myocarditis recovered with the rest at home or seeing doctors, cardiologists, echocardiogram, and the people did not go through any critical phase about that. We recently, I saw one patient 4 weeks ago, came to the hospital, and she was 44 years old. Problem, she was working at doctor's office. Somehow she did not want to take the vaccine. She came, we did whatever we can do, and she passed away after 2 weeks of the hospital stay. She died. The question is that when we were talking to the family, and I asked simple question, I said that all she had access to the vaccine in January and February. Why she did not take it? And family said, no, she had some misconception that she did not want to take it. Now the question is that very simple. You have a vaccine in the office. You did not want to take it. And the problem is that she actually lost her life. So lot of question comes that which vaccine is best, which vaccine I should take it. India has 3 vaccines, Sputnik, Covishield, and Covaxin. 3 vaccine mechanism, 2, Covaxin is only inactivated, rest 2 are vector based. What it means that they are mimicking that the virus is entering in the body, COVID virus, but it's not the COVID virus. One vaccine, Covaxin, has an inactivated virus. 2 had a virus, it's called vector virus, basically the carrier virus. So it does not give you the COVID with the vaccine. The second misconception, I'm talking to so many people in India, and this is the concept they have, that, oh, this is the dead virus of the COVID, and if I take it, there is a possibility I will get it. I think that's a misconception they have. Not to worry about that. It's a chemically dead virus. You should take it because one thing, and it's a very important, only 3 vaccines in the world has a more than 90% of the effectiveness. One is a Pfizer, second is Moderna, and third one is Sputnik. That's made in Moscow, Russia, and Indian government actually gave the emergency use authorization in April. The one more thing about getting vaccine and the side effects. I know that this is very important, that people are getting local side effects. If I have to put it the vaccine side effect in the US, I would tell you the vaccine side effect is more than the flu vaccine, but less than the shingles vaccine. It comes in the middle. So if you are taking shingles vaccine, the chances are less reaction than the shingles vaccine. I had few patients, they got the lymphadenopathy after the vaccine, mainly with the Moderna. Lymph nodes were so large, you feel that this is something like a cancer, but it went away in a couple of weeks. Some people got the rash or patch at the injection site. It got better with the 2-3 weeks. I also, since Dr. Gupta mentioned about the antibody infusion, we had one patient came from Kumbh Mela this few months ago and came back positive for the COVID. And we knew that the only treatment we can get it is antibody, and he got better in 48 hours. So I think if you have access to antibody, if a high risk, you should definitely get it. The second one, if you have any access to oxygen concentrator at home, you can use it, but please use it up to, like, if your oxygen level is dropping up to 88%. If it drops 87, 86%, please go to the hospital. The reason behind that, because if you get the pulmonary fibrosis, it becomes very difficult, and sometimes it might not be the reversible. So we have a people that they are waited at home and end up in the hospital with pulmonary fibrosis. When they come to the hospital, as Dr. Gupta mentioned, our first line of treatment, we use remdesivir, and I have prescribed probably for more than 150 patients in the hospital. And my personal opinion, not looking at any study, if it's given in the early stage, it works very well. I have not seen any single patient when we use in the early phase, there was any difference in the outcome. But only thing is, if we use in the late phase, we had to end up with the toci, that's another medication, did not respond well to remdesivir, and those people stayed longer in the hospital. So the best thing, if you want to get it remdesivir, you don't need that if its oxygen saturation is 88, 89%. But if you have comorbidities, I think best thing is to get it. And I know that we are reading a lot of articles with that, whether it's a true medication in India with the wild same remdesivir, but please just, I think now government is taking over, so hopefully everybody can get the appropriate medication. Side effect from the COVID itself, I know that there are a lot of patients, recovery after the COVID, they they had something called chronic fatigue syndrome. It's syndrome that comes with the profound weakness. Weakness means for 2 months, they had a hard time moving in even in the house with the shortness of breath, other issue. I think this was an important thing to remember, that drink plenty of fluid. You should feel better with that. I know somebody just wrote the question about the treatment for the second and third wave. You know that I would go with this variants part with the second and third wave, because if you know the first, actually the variant we had it alpha, and that was from the UK, initiated in the UK. Second one was from the South Africa, and the third one now Delta. The fourth one is Delta. Delta, and so many questions for the Delta waves. The important thing for Delta waves, vaccines are affected, all the vaccines. The question is that whatever they are working with the alpha and the other variants, it's probably reduced the effectiveness for the Delta, but it does work. It's not completely not working. That's a Delta plus, yes. The best thing, the study is done in the UK by public health system, and they noticed that the Pfizer and Moderna are working almost more than 88% for this Delta plus variant. We do not have any peer review for that. So hopefully we'll get it soon for peer review. And once we get it, we will have more information. But I think the Delta waves, it's still covered by the vaccine. So the best thing, take home message for everybody, whatever vaccine you can get it, please get it vaccine. Last thing about coming back to the hospital patient. I just said one patient came back to the hospital 2 days before. He's a 26 years old on dialysis. And what happens? He got the vaccine, both doses of Pfizer. The problem that he had, his immunity was almost zero. So any transplant patient and dialysis patient, sometimes you might not see the immunity. The reason behind, to remember this part, if you have any family members or if you have a patient with the dialysis or any transplant patient, mainly kidney, heart, liver, please tell them, take all the precaution to protect them, because even if I'm vaccinated, fully vaccinated, I can become a carrier of this COVID-19 virus and I can give it to that person. Probably nothing will happen to me, but I was transferring this disease from me to the other person who actually, even if vaccinated, does not have the immunity. And this is almost, I would say, the studies are going on in the US, almost 67 to 80% of the patient, transplant and the dialysis patient, they do not have the immunity after getting even vaccine. So please be careful if you have anybody with this one at home, or immunocompromised, somebody's on steroid, chronic steroid, somebody's on immunocompromised drugs, cancer patient, please be careful. Don't keep any false hope that they are vaccinated. Sometimes they might not have immunity. And this is very, very important. Now, few things I noticed that the patients went home, we discharged the patient from the hospital. Only 2 patients came back after so many discharges, and they came back with the multi-organ failure. So their liver function tests were like in 2,500 to 3,000. And also the kidney numbers were like almost 15 times higher than the normal. The question is, we could not figure it out. What was the reason for that? We treated them, but both of them, they died in the hospital within a week. So we were a little scared about that. And this happened like almost 7-8 months ago, that we were not sure. The treated patient with full antibody, we checked it in the hospital, went home without oxygen and coming back with this. So I would still consider, if somebody calls you, went home, treated well with the COVID, and if complaining of shortness of breath, please pay more attention and just give all your priority to that patient, because that patient might be going in the multi-organ failure. At least baseline you can do is to get the blood test quickly, and that will be very helpful. I know the children part. I'm trying to cover some of the question. So when we saw in 2020 beginning, there were like 3%, less than 3% children were affected. But at that time, they were getting inflammation in their coronary arteries. It's a Kawasaki's disease in the children, some of them. So there were cases reported. So some of the kids were getting really sick, serious. Now we have seen it's close to 22% children are affected. Now 22%. So experts are thinking two reasons. One, because US is covering so many communities and also the population with the vaccination, so that their incidence is going down with the younger people. But the children, now they are going to get the vaccine because Pfizer is approved for 12 years and younger or older. So that is going to help everybody. I think the take home message with this one, COVID-19, things are changing every day. As the treatment option, what we thought in the beginning, change after certain times, is changing. We do not know what will be the outcome, but I think entire world has to be vaccinated before you can go out safely. Because if you are traveling international, you are going anywhere. This is very, very important thing to remember that. And I know that I will be more than happy to take the question with Dr. Gupta. Yes.
Thank you. Thank you, Himanshuji. That was a very good message to all of us, including US, which is very new. This variant is in United States, in 41 states now, actually. So it's growing. So I think we all will be in the same phase, no matter it's a time difference, but all of us will go through this phase. So, but the only advantage is, as we all said, vaccine, right? Vaccine is somewhat protective. So the question is the Indian vaccines effective against Delta and Delta Plus? Is there any information we have so far?
Yes. So they are studying right now. In India, the study is going on, and it's definitely effective. But what actually they're telling compared to the alpha, this is reducing by 2 to 3 fold. Effectiveness is reducing by 2 to 3 fold. So what it means, the effectiveness probably you have 92% with one variant, probably you might have 80%. But still, what I would think personally, do I have any alternatives? And if answer is no, because all we have is vaccine. So I would suggest to take the vaccine and take the precaution to protect yourself, because this Delta variant is spreading so fast. So if you go to the social, if one person has a chance, and if it's 100 people are together, I think 70 will get it. So this is the problem we have. And now we are getting a little scared. Once everything is reopening, we do not know how things will go.
Yeah. So is there any difference in the presentation and management between the second and third waves? So India says they have already started the third wave now. Avinash, do you have anything to give us any information about what exactly, is there any difference, second or third wave?
Well, the third wave, the virus mutates constantly, and most of the time it becomes more easily transmissible, and it is not necessarily more virulent, but it is more transmissible, and that's why it's a matter of time before the third wave comes. But fortunately, so far the data shows that the vaccines are still effective against the new variants. Actually, I just attended a conference this morning, which says that there were like some cases of COVID with Delta in India, and none of them died, or none of them got I mean, some of them got hospitalized, but they didn't even need oxygen. So it is, you can still get the disease, but you won't need oxygen, you don't need hospitalization, you won't die from it. So, I mean, it's still the vaccine is still the answer.
That's somewhat promising, right? So,
Yeah.
so there's a question from Shachi. We finished both the doses of Covishield 3.5 months back and had COVID 2 months back. Still, our antibodies are not formed. Please advise. Himanshuji, if you can
Yes.
explain what this antibody thing.
Sure. So I just want to give you the brief introduction. When you get the COVID infection, natural infection develops nucleotide antibodies in the body. So our body produces nucleotide antibodies. When you get the vaccine, the antibody is different. It's called spike protein antibody. So when you go for the blood test, and if you got the vaccine, but if you check for other antibodies, you might not see that that antibody positive. So you have to ask first, is a spike protein antibody? That's a very important thing. Second thing, if you get the, I just would give one more thing. If you get the natural disease, COVID-19, and people are telling, oh, I have the immunity, I already got the antibody, I had COVID-19, my body is producing natural antibody, why should I need the vaccine? Why should I need outside, chemical? This is what they believe. All the studies, we looked at that, probably more than 50 studies. Average antibody stays in the body after natural vaccine is 9 months, 8 to 9 months. So this antibody disappears. The problem is that you would not know when your antibody is getting zero, and by that time you would not have any protection. So the best thing, irrespective of anything, whether you have a natural infection or not, you should get the vaccine. Second thing is, if you got the vaccine, spike protein antibody is the only antibody test. You should look for that. Natural disease, you see nucleotides, sometimes you might not able to see, but if you speak to the lab will know exactly.
Thank you, Himanshuji. So there's a question from Sonal. CDC has removed the mask mandate. Do you think people should still continue wearing masks since Delta variant is there now? It's so dangerous and contagious. Avinash, you can answer.
Yeah,
that.
I think that's a very frequent question. Here also people are coming from India, and we have social gatherings, and we don't wear masks, but so we are advising people coming from India to quarantine themselves for 10 to 14 days and still wear the masks. So here also the Delta variant is a concern. So we should still, like Dr. Pandya said, we should take the vaccine and still follow the precautions of COVID appropriate behavior.
Yeah.
Right.
Thank you, Dr. Avinash. So I would like to now invite Dr. Anil Jain, because we have a set up question, and Dr. Anil Jain is president of President Hospital Board Raipur, president AAPI Raipur. So I would like to request him to follow the Q&A round along with the IMA facilitator.
Thank you, Mr. Ganesh. Am I audible?
Yeah.
Thank you, Mr. Ganesh and AAPI to give us this opportunity to interact with the so learned people. I take this opportunity to introduce Dr. Mahesh Sinha. He is present president of Indian Medical Association of Chhattisgarh. And he's serving the Indian Medical Association since more than last 30 years. He is an anesthesiologist and intensivist as well. And he's in charge of various DNB courses in anesthesiology and intensivist. I request Dr. Mahesh Sinha to brief us about the COVID situation in Chhattisgarh and his inputs. Dr. Mahesh Sinha, sir.
Yeah, good evening, everybody, and good morning in USA. I had some interaction at the start of the session with Anupama and Ganesh. So the situation is improving in Chhattisgarh, and most of the country except a few parts of the country where we are getting now Delta plus variant. So this is a big concern, and the question was raised about the mask. I think the COVID appropriate behavior we cannot drop anywhere in the world. It is too early, because today only I learned that Israel had again brought it back, masking. Although the Israel is the one country which has got the highest number of vaccination. Nearly, they say, the whole population is vaccinated, but they brought the masking today again. So this COVID appropriate behavior has to be followed, and particularly the country, huge country like India, is thickly crowded, or everywhere there's a crowd, the marketplaces. So we cannot drop our guards too early. It will be disaster because the vaccination is still not complete. There is a lot of vaccination hesitancy also. There is a lot of confusion in the rural population about the side effect, bad effect of the vaccine. Everybody is trying to go through those myths, but it is difficult when a village or that rural area in India goes through that thought process. It becomes very difficult to root out this thing. We have a very nice presentation from two of the learned people from US. What they have said, they have raised equal number of more new questions. So it will be the COVID is such a complex thing that we are learning with the mutation, with the vaccine, and there are so many things like the antibody. Here the people, they go and get the antibody, they don't know what antibody they are getting, then what will be the impact on that. Like Dr. Pandya said, which antibody you are getting and for what purpose. So there are different things in India. It runs on a different scale where people get themselves treated by themselves, and the complication like mucormycosis, which is unique somewhat to India, is because of this over and undue treatment by the people themselves and by the doctors also. According doctors mean there are a lot of people in India known as doctors, but they are not qualified people, but practicing in every nook and corner of the country. So this is a big issue. I would like to ask one thing from Dr. Pandya about the Johnson & Johnson vaccine, because now it is going to come in India also in next month, because it's a single dose. So that many people may be opting for it. What is your view about that?
Sure. Thank you, Dr. Sinha. So Johnson & Johnson, if you know that in the US, they had to pause it for certain weeks, because on the childbearing age of women, they develop thrombosis with this one. So I think they had to hold their administration, reviewed by FDA panel, and they came back. So I would suggest that if somebody, the female between like 16 to 45 years old or 48 years old, they should avoid that Johnson & Johnson, but rest of the people can take it. The reason is that they are still reviewing, but I think even if very few isolated incidents happen, to be on safe side, if you have a choice, mainly for the female, they should get the other vaccine, but all other people can get this vaccine. There is no problem. And it's a good vaccine. When we looked at that, the comparison between Pfizer and the Moderna, the effectiveness is not coming that closer to that. But the best thing is that going into the severity of the severe disease and also hospitalization, also it coming closer to this Pfizer. So I would say we should just go ahead with that one. It's a one dose and it's effective after 2 weeks of the dose. And it's an important thing and very good thing about this vaccine in India, you can send it to any corner, because Pfizer require -70 for the storage, and it's a very difficult to maintain in India. And second thing is Moderna also require the refrigeration. So I think Johnson & Johnson is the best solution. You go, you give it to the patient, that will work out very well.
Okay, that was a very nice description of which population should avoid it, because Lot of these things are not known to the people, even doctors don't know them. Switching on from this current topic, I am coming to the general thing like Indian Medical Association and your association, AAPI and NACHA. They want to help people in India, and already they have been helping out. My humble suggestion is that in India, there's a one thing, we don't have a social security, and even a lot of doctors, they don't have insurance, life insurance also. So many families of doctors, professionals, they are facing a lot of problem. Indian Medical Association National have started a COVID Martyrs Fund. So it is my just suggestion that if you want to help, you can go through that channel also. It is I can share the what are the details and account to both the bodies, NACHA and to AAPI. Thank you for your nice efforts and your Sunday morning taking out time to help the Indian. Thank you.
Thank you, Doctor.
You can take on, Anil, for the questions.
Thank you, Dr. Mahesina, sir. We have a few questions to Dr. Pandya and Dr. Gupta. You have already answered, you have covered in your lecture a few of the questions. Mainly the questions are regarding the post-COVID complications. The patient recovered from the COVID and discharged from the hospital, then he developed some complication. It's like new onset diabetes. How is the prevalence of new onset diabetes in your place, and how it can be prevented and can be managed?
We have noticed that, and this is extensive research is going on for this topic, new onset of diabetes in the post-COVID patient. So we are still waiting for scientific evidence, but we have noticed that sugar is going up. Few reasons, because during that time, as per the protocol, hospitalized patient, they are getting steroids, mainly the dexamethasone, decadron, 6 milligram daily for 10 days. We all know that steroid is also associated with high sugar and uncontrolled diabetes. But the studies in US, UK is going on, and so far we do not have definitive answer for that. But we have noticed there is an association of new onset of diabetes. But when we looked at the patient population, mainly people who are obese, their BMI is higher. Also, they have some comorbid condition, not the diabetes. They are prone to develop this compared to the healthy population when we looked at the people who are having high sugar. So it's still going on. We do not have any scientific evidence suggesting this is the reason, but studies and research is going on for this. But we also know that, and most of the time, I had few patients, we were able to cut down on the sugar medication after 6 months, but still they are on metformin. We started with the Januvia, and then some of them got insulin. Slowly we cut down on that. So I think some of the researcher, but still it's not sure, they are thinking it might be some effect on pancreas, but we would know probably in the future.
Similarly, this post-COVID complication, after the discharge from the hospital, patient develops breathlessness, off and on breathlessness. So how is the prevalence over there and how you manage it?
Actually, I am a cardiologist, so I have seen, asked several questions that, patients get heart attack or cardiac arrest or breathlessness after COVID. So first thing I would like to say is that, all the other disease we face will not take a vacation just because COVID is here. So they will still be there. And we know that heart attacks and strokes, they happen because of plaque rupture. So there is plaque in our coronary artery or carotid artery. And if there is inflammation, they will rupture. And after the rupture, there is clot formation. And we know that after COVID, there is increased thrombosis also. So because of this plaque rupture and thrombosis, we get more heart attacks and strokes. And sudden cardiac death can also happen from massive pulmonary embolism, or we know that there is some myocarditis and there may be some arrhythmia, and that can lead to sudden cardiac death. And I'm glad doctors in India are using a combination of atorvastatin and baby aspirin, and they are advising patients to take it for a month. But I think it should be continued even beyond 1 month, because the only thing which can prevent a heart attack or a stroke is a statin and an aspirin, unless there is a contraindication to it. And I would also take this opportunity to tell that I tell my patients who are hesitant to take the vaccine that just Google how many people have died of COVID. In America itself, more than 600,000 people have died. And how many people got the vaccine already? Millions. And how many people died after getting the vaccine? So you have to weigh the benefit and risk. And usually I am able to convince them because they are all high risk. And when I point out that, you know, if they get COVID, they may not even make it, then they do get it. And about the post-COVID breathlessness, as we, I have seen that, you know, there are a lot of post-COVID recovery programs, and basically there is deep breathing exercises, which in India we call it pranayam. So yoga, pranayam, meditation, they do help. So breathing exercise, deep breathing exercise is very important for those. And actually, you had asked me a question in the email about vaccine-induced thrombogenic thrombocytopenia. And that's what happened with J&J vaccine. And but the incidence was very rare. I mean, 6 people out of 7 million. So it was very rare. And as Dr. Pandya mentioned, it was only in women from age 18 to 48. So that's why when they came back, they recommended that those people should not take the vaccine. And you had also asked about mRNA induced. So I saw the first case after the email, actually. There's a one of my friend's daughter, 15-year-old, she went for a routine blood test after the vaccine, and her platelet count was 9. So we thought it's a mistake. So we repeated it again, and it was 8. So we sent her to the hospital, and they got IgG, immunoglobulin G, and also solumedrol, just 1 dose, and she was sent home, and next day her platelet count was 138, and she is fine. So these vaccine-induced myocarditis also has been reported since April 2021. We have about 1,000 reports of myocarditis. And usually they are in people young, 16 years, 18 years, and adolescents. But they respond very well to treatment and they recover. And so far it has not been a concern to not give vaccine to them. So that's what I would like to say about it.
Sir, I want to one question.
Yeah.
Sir, one patient is going on postpartum myocarditis 2 years back. Isn't he is able to take vaccine or not, sir?
Definitely, yes.
Yes, sir.
Yeah.
Just now you asked about the myocarditis, so I am raising the question, sir.
Yeah, so actually, if somebody has postpartum cardiomyopathy, she is at high risk of having adverse effects when she gets COVID. So she should be protected by taking the vaccine. And as I mentioned, the myocarditis is very rare after vaccine, and it's usually the recover from it, and it's usually in young people and adolescents.
So I advise him to take a vaccine, sir.
Yes.
Okay, thank you, sir.
Dr. Gupta, actually, there were a few cases in India where the young people who recovered completely, physically and everything from COVID, and they started doing their routine, and suddenly they have died. There have been few incidents while doing some exercise or doing morning walk and also. So what is the suggestion post-COVID recovery, how the people should go on to their natural life?
Yeah, they should see their doctor definitely to assess their cardiovascular risk, because as I said, I mean, they may have some underlying heart issues, which is not manifest. And as I also said, empirically, they are being given a statin and aspirin, which can prevent it. And then, of course, they have to have their risk stratification and undergo a stress test or echo if they need it. But before, American Heart Association recommendation also is that after age 40, if you are going to do vigorous exercise activity, then you should have a treadmill test first to make sure that you are safe doing that. So you should consider that.
Here in India, we also found that there is some sudden death in a patient who are either asymptomatic COVID positive or they are non-COVID. Do you think that this non-COVID sudden death in patients is related to COVID, or the severity of COVID is related to sudden death? Or even the asymptomatic people can get it?
Yeah, sudden death, as I said, it can happen from massive pulmonary embolism because of increased risk of increased presence of inflammation and thrombosis, and also myocardial infarction or some arrhythmia. So that can lead to sudden cardiac death. So again, the Indians, that's a different topic, but Indians are at very high risk of having a heart attack and a stroke. 25% of heart attacks in Indians happen below age 40, and 50% of heart attacks in Indians happen below age 50, which is unheard of in any other population. And it's genetic predisposition, LP little a, and they are small dense LDL, so atherogenic dyslipidemia. So they have premature CAD anyway. And add COVID to that, and they will have more sudden cardiac death from heart attacks and strokes.
There is a question regarding the second wave and the third wave, management of second wave and third wave. As we are supposed to get this third wave also, Delta variants are being diagnosed here in India. What do you think, how we can prevent? Is there any specific policy or preventive method, or is there any difference in the management of this third wave or the Delta variant?
I think it's just the variant. The treatment is almost same for all these variants. The reason is that only thing we have noticed that's a virulence of the organism. What it means, the infectivity, it's very high with these variants. So people are going to get easily infected. So if you look at the variant from March 2020, September, October 2020, then the spring 2021, all we have noticed that the spread is so fast. So the best thing we can do for the prevention, take all the precautions that we were taking it from beginning, wearing mask, frequent hand washing, try to avoid gathering with too many people. And if you have somebody, guest is coming to your house or you're going somewhere, just make sure nobody's sick there before you go, because you do not want to get it. And the problem is that sometimes people are healthy, they can get this virus. The problem that if they have their parents at home or somebody immunocompromised, if they get it, the mortality is much higher. And we have noticed that in New York, in March 2020, most of the more than I would say 80% of the people above age of 75 died in the hospital in March 2020. The reason, not a single person left the house. Most of the people did not leave the house. They got it from their kids because they had to go to work. So the problem is that any variants, the treatment is same, but the only thing is you need to avoid getting infected. Just the prevention. As a physician, as a patient, you all have to take whatever precaution you can take it, but try to prevent that getting into that. So I think only thing is you go, even if right now, go to the only places where it's essential that you have to go, not the social. I would try to avoid the social things.
Is this
Dr.
variant
Anil,
going to affect the children more in comparison to adults?
Yes. So as I said, in 2020, we have seen in the kids 3% positive. Now it's 22% positive. So it might, the vaccine is number one reason. Probably so many adult population got the vaccine, but again, that everybody is getting infected. So it's not only just for the adult population. Yes, it's kids are also getting infected. Most of the kids are recovering at home. And I know somebody asked for the Kawasaki's disease and symptoms. I'll tell you this time. The Kawasaki's disease is something majority of kids, the median age was 9 years. Mostly with nausea, vomiting, rash, fever. When it progresses, it goes in the cardiogenic shock, low blood pressure, hypotension, fever, breathing difficulties. So most of them are end up in the hospital. So definitely it's in the kids, but we are not seeing, thanks God, this Kawasaki's this type of disease right now compared to what we have seen earlier.
Dr. Anil, sorry to interrupt. There is time check. We have hard stop. So maybe we can proceed for closer. And what we can do, we can share the question to the panel and we can get it answer offline.
Thank you, Ganesh.
Yeah.
Go ahead.
The President of Indian Medical Association, Raipur, Dr. Vikas Agrawal, to present vote of thanks.
Hello, everyone. Am I audible?
Yeah.
We feel really proud while seeing Indian tricolor high in all other countries. This is possible just due to our Indian colleagues all over the world, like members of AAPI and NACHA. COVID pandemic has brought whole world under one screen via digital platform. Now we can share experiences via this platform. We feel privileged to hear Dr. Avinash Gupta and Dr. Himanshu Pandya today. In today's interaction, I felt there is no difference in presentation in US and India. Individual patients were there in first wave and almost whole family involved in second wave. Now we are going to work in third wave by our own overconfidence and mistakes. God knows what will happen, but we have to be prepared to tackle third wave in India. It was really nice, and I express my sincere thanks on behalf of IMA Chhattisgarh and IMA Raipur to both of the learned speakers today. I also pay my sincere thanks to Dr. Anupama, the President-elect American Association of Physicians of Indian origin, and Mr. Ganesh Kar, President North American Chhattisgarh Association, to organize today's webinar. I thank and wish good wishes to Mr. Ganesh to promote CG Chhattisgarh on world map, and also Dr. Anil Jain for his untiring effort for this webinar. We hope to have similar webinars, knowledge and experience sharing interactions in future as well, which will benefit people of both the countries definitely. Once again, I thank you all to the participate in webinar and especially to all our viewers without whom no webinar can be claimed successful. Thank you all.
Thank you. And
Thank you all.
thanks a lot and best wishes to all. And please maintain those safety measures. Don't be relaxed at all. For next 1 year, I would say at least a year, we have to wear the masks. Here, I never go out without a mask, even though the cases in United States is less than 20,000 right now. But still, we wear masks everywhere we go out. So we are not going to relax. So that's a minimum I think we have to follow. Thanks and have a nice good evening.
Thank you, everyone.
Thank you.
Everyone.
Thank you.
Thank
Thank you, everyone.
Thanks.